Welcome everyone. So today's webinar, we're jointly presenting the content from the Technology-Enabled Care Services and the Integrated Care Pioneers programs at NHS England. And as Beverly mentioned, the purpose is really to help commissioners and other health and social care professionals to understand how technologies can bring benefits to a whole health economy, and also to provide you with some practical tips on how to commission, procure, implement and measure these types of services effectively. So I'll just walk you through the agenda briefly. My name is Annie Thompson. I'm the Technology Enabled Care Services Programme Lead at NHS England. I will pass on to my colleague Ashley Moore to say a few words in a moment. Then myself and Tim Ellis will talk you through an overview of the Technology Enabled Care Services resource for commissioners, which we recently published in January. And then we will have two case studies about how these types of technologies can be commissioned and used in practice, one from Airedale and one from Herefordshire and Coventry. And then we'll finish up with an opportunity for everyone to ask questions. So before I move on, if I could just ask Ashley Moore to say a few words about the Integrated Care Pioneers programme.
Hi everyone, my name's Ashley Moore. I'm from the New Models of Care team at NHS England, and I'm part of the team looking at the Integrated Care Pioneers support programme. There are 25 pioneers across England, and today's webinar arose from a series of conversations I've had with pioneer sites over recent months. That technology-enabled care services was a very, very high area of interest for pioneers working on models of integration. And so this is a result of conversations that Annie and I had and Annie's had with Bev at IQ. So hopefully all of you pioneers joining today are going to find this interesting. I hope it reflects on the conversations we've had recently. And I'm very happy to, either myself or other pioneer account managers are very happy to pick up with our pioneer sites following this call, anything further you'd want to explore or take up. That's all from me now, and I'll hand back to Annie.
Thank you, Ashley. Next slide, please. So technology-enabled care services, we recognise that these types of technologies can help to enable the remote exchange of information, usually between a patient and a health or social care professional, and they can help in assisting to diagnose and to monitor people's health status. So I think a really important message that we've tried to make very clear through the Technology Enabled Care Services programme is that it's not just about the technology alone, and that the technology itself can't deliver a transformation in care, but actually when it's embedded into a wider package of care and new ways of working, it can be really beneficial. And that's why it's really important to think about all of the different partners that you need to work with across a health economy, across health, social care, voluntary services, patients and carers, when planning for and implementing these types of services. So this slide provides a bit of a view of the policy context and the different transformational programs taking place at a national level which TECs can support, including some of the key priorities in the 5-year forward view and in the National Information Board framework. And you can read the details of these within the TECs resource, so I won't go into those just now, but this is really just to illustrate that actually these types of solutions can help you to address a wide number of priorities across the board. Next slide, please. So when we talk about technology-enabled care services, really we've placed a number of different types of technologies under that umbrella. And those include telehealth, which is about the remote monitoring of patients in their own homes, telecare, which is about technologies that can be used in people's homes or in communities, such as emergency alarms and fall alarms, telemedicine and teleconsultations, which can enable peer-to-peer support between clinicians and patients, telecoaching, and also self-care apps. And really we want to encourage people to think about a whole range of different types of technologies and solutions that can enable and benefit different care pathways. Next slide, please. So here are some of the details of the things that you will find in the TECs resource. So the core of the TECs resource is broken down into these 5 areas of strategic planning, which has some details around things like how to do risk stratification and case finding, what the benefits of texts are to help you build a benefits case, sources for investment and funding, and a checklist which is against actually each of these sections. It has a useful checklist with the kinds of questions and things that are useful to think about as you're going through and planning and procuring and implementing technology solutions. Under procurement, there are a number of commercial tools that can help you to identify the right types of technologies and help you to select what would be best for the type of problem that you're looking to address. Under implementing text, you've got some tips and information around how to tackle information governance, and again, a checklist around implementing that. Under measuring impact, we have an evaluation framework for technology-enabled care services, which is essentially a sort of a 6-point framework which covers a range of different measure areas with suggested metrics that can be used against those, really to help to try and build consistency in the measurement of technologies. And then finally, under improvement, we've got a range of case studies and some details also then about further resources and useful reading. I'm going to hand over to my colleague Tim Ellis now to take you through the next few slides.
Thank you, Annie. Can everybody hear me? Great. Thank you. So we just wanted throughout the guidance really to highlight that whereas in the past a lot of the focus of text has been on sort of frail elderly to some extent, if you look at the literature now, and there's literally tens of thousands of papers, there's applications all the way through from pregnancy, childhood, adolescence, all the way through adulthood to end of life. And a core task that everyone has to undertake when they're implementing new services is to produce the business case and map out the benefits. So we put a series of slides in the pack that just say, in terms of the type of solution, what outcomes might you expect? It's obviously dependent on how well these things are implemented, but also what type of benefits are being claimed by people who have successfully implemented these solutions. And really, it's as a guide to say, when you're putting forward your case for change, you should be considering some of these opportunities. Next slide, please. One of the other things we wanted to do is, when we're thinking about the structure of CCGs and how sort of the commissioning plans are developed, often it's under portfolios. And so what we've done throughout the pack is we've said for things like primary care, community care, acute elective, urgent and emergency care, for example, we've tried to highlight how text could be of value when people are developing their commissioning intentions for the next 5 years. Just really to make sure there's that conscious decision to say, yes, we've considered whether these have a role or not. So you'll find there's, as I say, quite a set of prompts to say how everything from apps to full-blown telemedicine can be of benefit. Next slide, please. There's a much broader range of resources throughout the toolkit. So we've got some exemplar pathways, and what they'll do is take, for example, the COPD pathway from someone having an exacerbation, going through an emergency admission, back through care in the community and out to self-care. And what we've tried to highlight is how each of the modes within the... Excuse me for one minute. Sorry about that. So what we tried to do is say how the different modes of text can support that, so that throughout there we can have things that support medication reminders, that remote consultation, actively enable the family and carers to be engaged, through to specialist remote care and support. So we've tried to give real examples. Similarly, under the planning checklists, again, at each stage that Annie mentioned, such as strategic planning, procurement, implementation, we've laid out some key questions that are really just an aide-memoire to say, have we covered off everything that we need to at these places? And linking to further resources, there we've got lots and lots of helpful links, we hope, but also support to the latest evidence review, all of the papers that were published in 2014. So I'm going to pass over to Rebecca now. Thank you very much.
Rebecca Mallin here from Airedale NHS Foundation Trust, and I'm presenting with my colleague from Airedale Wharfdale Craven CCG, Stephanie Lawrence. Next slide, please. So we are unashamedly jumping on the back of an awful lot of media attention recently, including the 5-year forward view. The last year has been rather crazy for us here since the work we're doing jointly as an acute trust and with our commissioners has been featured in many national media. Whilst all this is really good news for a DGH and a commissioner on the edge of the Yorkshire Dales, the headline in our local paper, the Craven Herald and Pioneer, is that sheep trade sold. So that brings it back to our local population, and what we are doing that is being held up as being slightly different to deliver care to our local population. Next slide, please.
Hi, Steph Lawrence here from the CCG. This slide shows our CCG population area, and as you can see, it's a big geographical area with approximately 156,000 patients within that area and 17 member practices. Next slide, please. This is our shared vision across our health and social care economy that we call Right Care. It was developed by Airedale Foundation Trust but has been adopted by the health and social care community as our shared vision for what we want to see in terms of how we deliver care in the future. And as you can see, it's based around the individual, the patient at the centre of this, orchestrating their care. Next slide, please.
So just to take you through some of the specifics of what we have done, and I know there's been an awful lot of talk for years around various teles. So we are talking teleconsultation, also called telemedicine, so video consultation via secure and encrypted links. So we've tried this in a number of settings now. We certainly haven't discovered all the applications, and I'm sure you'll have many suggestions on how it could be used. But just to draw out a few of those boxes, the top right corner, we delivered speech and language therapy to some people with Parkinson's. The next one, along with the lady in the blue top, we delivered and still are delivering video consultation to people in the last 12 months of their life. And then the top two squares to the left, we're delivering consultation to patients in their own homes and also patients in nursing and residential care homes. Our journey started, however, 8 years ago in offender health, and we still have that model today, where 13 prisons across England make referrals to secondary care, but those referrals come through to Airedale Hospital. We make a judgment on whether they're suitable for telemedicine or not, and then schedule them into a clinic. On the day of their consultation, the prisoner will attend their healthcare wing and undertake a consultation via video. Some specific challenges in delivering to that cohort of patients, some around the natural challenges they face in a prison environment, which results in a high number of DNA or truly could not attend. And then we had some internal challenges that meant when you were dealing in a small number of prisons, maybe up to 5, 10, that didn't generate enough referrals to fill a clinic. So then we were asking a consultant to walk down a corridor to a room where we did video, and they were delivering 1 to 2 consultations. So there's definitely something which we'll come on to later about delivering at scale. Next slide, please. So just to expand a bit more on the care home and patient-owned homes. Right now we're live in 210 nursing and residential care homes across England, and just across Airedale, Wharfdale, Craven, we are live in 31 care homes, all of which had 9 or more admissions in a 12-month period. We're live in 100 patient-owned homes, and that's largely people with COPD, heart failure, complex diabetes, and end of life. We have 30 iPads that we rotate around people who are in the last few months to weeks of life or in the last 12 months and require additional support. We also have community nurses who have the license to video software on their tablet devices, and they can be out visiting patients, and they'll maybe call back through to connect to someone with more specialist skills. We're also running something, this is a fairly new trial called GP Triage, where we've taken a selection of care homes, and instead of them calling their GP surgery to request a visit, they are calling our telehealth hub, which I'll come on to explain that facility shortly. They will call the telehealth hub between 8 and 10 a.m. We will undertake an assessment by video and then onward refer to a healthcare professional if absolutely required, but ideally resolve the problem whilst we're on that video call. Early feedback from the GPs taking part in this trial has suggested that their visits to care homes has reduced by more than 50%. So our telehealth hub is a 24/7 facility, and it's staffed by experienced nurses. So we made a conscious effort to staff this facility with band 6 and 7 nurses, so we are taking immediate clinical decision. We do have the ability to escalate onto a physician. However, the types of calls that come through from care homes and patients in their own home is really nurse-led. We escalate around 2%. One thing that has been of significant benefit is to have a shared electronic health record. So we are incredibly lucky that the majority of GPs across Airedale, Wharfdale, Craven use TPP System 1. In November 2012, Airedale Hospital took the acute module of System 1 and has been co-designing that with TPP. So that has immediately given us a shared primary and secondary health record. Later this year, our local authority will be joining, so we'll then have a social care record as well. Next slide, please.
So when this first started, we had to decide how we would select the homes that we were going to put this service into. Some of that was affected by technology and whether we could enable it within certain homes. But we also looked at those homes who had the highest number of A&E attendances, ambulance call-outs, GP call-outs, etc. We also considered geography. So as we've already said, we're a large area with some very remote parts to the district. So we looked at being able to link up people that were furthest away so that they could access this type of service. We also looked at the size of the care homes as well, because it was felt that the bigger the care home, the more impact we could potentially have. So in terms of scale, as Rebecca said, that we're currently in 31 nursing and residential homes across Airedale, Wharfdale and Craven, but there are 67 in total, so there are still further homes out there without telemedicine at the moment. And some of that is dependent on getting those homes signed up to it. In terms of funding, we've had to tap into the funding that's been available to enable us to be able to commission this service. And we were lucky enough last year to be able to get some money for the North Yorkshire area, which is one of the reasons that we're now in the majority of the Craven care homes.
Just to follow up on something Steph alluded to there, the bullet point that says engagement, 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 and getting the care homes signed up to this. Not everybody wants it. Not everybody wants someone, a nurse or anyone coming in over video into their care home. And something we underestimated right from the start was the amount of engagement we need to invest. And that's both pre-implementation, during, and then forever after. It's not a case of implementing and popping in for a monthly phone call or monthly visit or video chat to see how they're getting on. It is constant engagement. We do that, we line them up depending on the size and need of the care home. We'll either line them up with one of our project and relationship coordinators in the telehealth hub or link them up directly with one of our telehealth nurses. The next bullet point about collaborative coordinated care, of course, the benefits really only deliver if you are delivering this as one piece of the jigsaw across the whole system. So as an example, we work to understand the directory of services, so we know all the other services available across the patch, so that if we need a nurse to go and stir a strip, a cut, after a fall in a care home, we know who to call to do that. It really is vital to have buy-in from all providers across the patch. Technology, of course, since we started delivering telemedicine 8 years ago when we were using ISDN lines, technology has moved on enormously and continues to rapidly move on. We still, right now, are using Cisco Jabber. So the infrastructure we have installed at the hospital means we've got secure and encrypted video links. There's an ever-increasing amount of noise around the use of Skype, and we're watching that closely because one of the reasons we haven't used Skype for consumer was always around IG. However, I accept things have moved on somewhat, and the message we've received most recently is it's fine to use Skype so long as you make your patient aware of the risk. We've still, however, got the question of quality. For us, if we are having a patient consultation, we do not accept loss of lip sync or pixelation, and that's one of the reasons why we are remaining for now with Cisco. Moving forward, there's a lot of noise about Skype for Business, the Microsoft link, and we'll continue to assess that. What is important to us, though, is that we've got the infrastructure to allow us to bring in other parties so we can have multi-way calling, and also the ability to send a guest license. So to be able to take this to scale with patients in their own homes, this is not about rolling out bits of kit. It's about people using their own devices, and it may start with a phone call, but then we may send them a one-off guest license to access a video call. Next slide, please. So this is quite a hot topic for us here in Airedale. Measuring, how do you measure the true benefit of deploying telemedicine? In the first year, 2012-13, of having this in care homes, we did our own internal audit. This year, or 13-14, we used Yorkshire Health Economics Consortium. So there's something there about thinking who is going to do your measurement. If we'd have known then what we know now, we should have been using independent evaluations right from the word go. And then thinking about what to measure. The quantitative side, the obvious ones are admissions. What impact is it having on your admissions and your A&E attendances? How is it affecting your length of stay and your bed days? But then thinking about how you do that measure. It's really challenging to have a control group because, of course, you can't control that control group. And one of the reasons we had a certain number of care homes with telemedicine was because they were a certain type of care home, maybe down to size or complexity of patient. So our control group, i.e. the care homes without telemedicine, are vastly different anyway. Do you look at before and after? Or do you have that comparator group? Do you look at it at patient level? And that was one challenge we came across, because how many patients' addresses in System 1 actually reflect the accurate address of them being in a care home? So do you look at it at a care home level by postcode and accept that there may be some houses either side of that care home with the same postcode? So really challenging on how to measure. If anyone wants more detail, or I'll be happy to share the specification that we used. So just to draw out some of the qualitative aspects of measurement.
Okay, so whilst obviously the quantitative side of things are really important, it's also really important to consider the impact of this on patients, their experience, and what matters to them. So in terms of being able to keep somebody at home, if that's the most appropriate thing to do for them, that should improve the patient experience. Also the staff in the care homes and the improvement for them. So if somebody doesn't have to go to hospital, they no longer have to send an escort with that patient and the person can remain in their own home. And the skills and competence of those staff, that they're able to be developed further and able to upskill themselves in terms of delivering this to patients in their own homes or within the care home setting. And that assurance thing, I don't think we should underestimate that. If you're a Band 5 registered nurse on your own overnight in a care home and you know that you can access a service with experienced, high calibre nursing staff to be able to keep that patient where they are, that is really, really important for both the staff in the home but also for the patient. Next slide, please.
So the results we did have, so this is looking at a 2-year period of care homes in Airedale, Wharfdale, Craven. Admissions dropped by 37%. Now if you look at the box down at the bottom, that gives you the actual numbers of reduction from care homes with telemedicine versus care homes without telemedicine. Next slide, please. And this takes you through the results for A&E visits. So a drop of 45%, but the actual numbers, 1,029 versus 327 in care homes without telemedicine. Next slide, please. Just wanted to draw out some of the typical outcomes that happen following a call from nursing residential care homes. I'll leave you to review the pie chart in your own time, but one of the challenges I recently had was, that's all really great, but what happens 5 days later? Are we just delaying things? So last Friday we spent the whole day locked away in a room with a local GP, a secondary care consultant and a telehealth nurse, working through the System 1 patient records of 40 patients in a care home with telemedicine and 40 patients in care homes without telemedicine, to look at what happened on the days following a telemedicine intervention. Now, I don't have all the figures yet. I'm happy to share them when we do, but the early indications showed, had the patients in the non-telemedicine care homes been exposed to telemedicine, their outcome would have been better. For the patients in care homes with telemedicine, it was an appropriate intervention and they did not end up being admitted or to A&E in the days following that intervention. Next slide, please. This is a snapshot of where those calls get onward referred to. So we do an assessment via telemedicine, and let's say Mavis in that care home has fallen, taken a bash, and we need to onward refer that to get someone to go and visit. This just gives you an example of where they are going to. ACCT is our collaborative care team. Next slide, please.
Okay, so in terms of what types of patients can benefit from this service, if we've had a resident fall in one of the care homes and maybe sustain a laceration, they're able to call the service and the nurse can actually assess the wound and make a decision on whether somebody needs to come to hospital, which obviously the benefit of being able to see that wound and the laceration and the extent of it means they can make that safe decision as to whether that could be safely treated in their own home, and that might be by the nurses or the staff within the care home, but it might be an onward referral, as Rebecca's just referred to. So it might be that we ask one of our community nursing services to go out and maybe steri-strip that wound, but what it does mean is that a lot of the time the patient can remain in their own home. But if they do need onward referral to ED, then that's fine, because obviously some patients will still require that. Next slide, please.
Just a sample of feedback, and I'll leave you to read this through maybe after the webinar. We have many, many case studies that we could share, so we've just pulled out some of the key comments. Next slide, please. Some of the practical challenges we face throughout deployments. Start with the top one, clinical engagement. It's a real mixed bag. Speaking from secondary care, I think what was of significant benefit was we started delivering video consultations within offender health. So that cut across every specialty in the hospital. So it wasn't seen as a respiratory project or diabetes project. So that was of great help in getting everyone bought in from the word go. Since then, however, because the work we are doing in nursing residential care homes and patient-owned homes is largely nurse-led, then we don't have as much involvement from at consultant level. We only recruit consultants who are happy and willing to undertake telemedicine consultations, and it is written into the job plans of all consultants. That does not mean, however, that every consultant at Airedale Hospital is dancing off the rooftops thinking telemedicine is fabulous. I think it's simply accepting it's not for everyone, nor is it for every specialty. Externally, we get, again, a mixed bag of views from primary care. The starting point some years ago was that's primary care work, hands off. I think some of our responses as a hospital was, but they're still turning up at A&E, and it's not the right care if on a weekend the majority of the beds are full of 85-year-olds from nursing residential care homes, if there is an alternative way to delivering that care. More recently, we're moving into co-design, so we accept, yes, it is care of a primary care nature, but how can we do this together? Technology I've touched on continues to evolve. It can be a challenge implementing in some care homes. We work with a technology partner to achieve as much connectivity in every room of a care home as possible. Collaborative working we've already touched on, and we have also touched on scale. Securing mainstream funding, as Steph said earlier, we've accessed various pots of money, but it has continued to be that. It's continued to be non-recurrent pots of money. And then the last bullet point, of course, we still have a perverse tariff. We are still, as an acute trust, paid more for bringing people in than keeping them out and delivering care in a different way. At some point, we're ever in hope that that will change. Current and future plans, co-designing, as I've just touched on, looking at how we can turn this into more of a proactive service rather than just reactive. Assessment of other techs, how can we bolt on other technologies to enhance the care, such as monitoring or such as fall sensors, the telecare that you see out there. Would it make a difference to the outcome if we could then beam in over video? I touched on earlier, I think future plans are to go at scale to patients' own homes, but that has to be by people using their own technology. Palliative care, we've only touched and scratched the surface of delivering care to people in the last 12 months of their life. The evaluation we're having done of on this will be published in summer 2015, but the early evaluation we're seeing is outstanding, particularly from a qualitative point of view. Enabling the hospital for full site video. There's something crazy about using video to deliver consultations, but expecting people to come to a fixed facility in the hospital in order to undertake a video consultation. We have to take the video to where our professionals are. And then the last bullet point is Vanguard. So if you can just move on to the next slide, please. We were delighted to be one of 29 through on Vanguard, and this is in the Enhanced Health in Care Homes. So I've put up there a link to the YouTube so you can see the pitch we gave that secured Vanguard. This is across Airedale, Wharfdale, Craven, Bradford and East Lancashire, so a patient population of 506,000. It's in partnership with a number of organisations, so NHS providers, both primary and secondary, commissioners, social care, third sector, care home providers, technology providers and academia. And it's all about We've already delivered video into care homes, which is allowing us to deliver reactive care, but how can we grow that to deliver reactive care so we can enhance the health rather than just improve access? So we intend to introduce self-care, so care home residents can tell us how they're feeling, optimise their health and communicate that message to an extended care team. We intend to extend the use of telemedicine so that we're delivering a fast and effective single point of access, have greater integration with other services across health and care, and then bring in remote monitoring. We're working with the University of Bradford on their dementia care mapping and enhancing the shared information platform, which I touched on earlier, by bringing in social care. Next slide, please. So thank you for listening. Any queries, you've got our contact details there, and I will now hand over to Nathan.
Slides. Good afternoon. Thank you very much. I thought I'd spend a few minutes just going through a few slides around some of the approaches that we've taken in Herefordshire and Coventry, where I've worked as Commissioner and within social care. A lot of it does mirror what we've heard already in terms of the very good examples from Airedale, and also that hopefully the very good examples you'll find in the text toolkit. And if we go to the next slide, please. Hello. Hello. Thank you. There we go. Right. So lots of pretty boxes on this slide, but really the view is to try and to say that in order to deliver a sustainable technology offer, it's really thinking about all of the elements that you'll find around this diagram, this circle. Obviously, funding is key, and for me, particularly from a social care angle, it's really looking at our partners in health and in housing in particular to see how we can work together to explore all of our objectives. And obviously put technology at the heart of the care and support offer. There are opportunities obviously from better care funds. There are opportunities in looking particularly at how we use housing and the different choices that are available to people and where technology can fit into delivering those services. From a strategy point of view, whether it be looking at prevention, whether it be looking at supporting people from hospital and reducing any delayed transfers of care, there are clear opportunities to realise both cost reduction savings and cost avoidance, but it must be clear to identify what exactly those are and how you're going to measure them, as was said in the Airedale presentation. And for our customers, for our staff, for the general public in particular, it's the information we provide them. The advent of the Care Act is really showing that, particularly from a social care point of view, we need to be very clear in the information we're providing, and the role, I guess, of our services and our media is changing, so that we're really looking more at being trusted advisors, allowing people choice to enable the other services they want to tap into. And from a technology point of view, that might be anything from individual everyday gadgets you can find in the high street all the way through to the high-end piece of technology to support vital signs monitoring, and particularly when we look at the Airedale example, things that are becoming more and more into the domain of people bringing their own devices, people using it not just for remote consultation, but equally using some of the technology for improving their social isolation. So awareness is key for all of our stakeholders, and clarity on what processes and what their role and responsibilities are in those processes. And from a partnership point of view, looking at, dare I say, other partners to be able to deliver some of these services. A good example being fire services and their potential as their capacity and their business changes, their capacity to be able to provide some of the responder services that I'll come on to. And most importantly, obviously, the service users, carers, families and staff. Next slide, please. An example from Herefordshire is the Falls Responder Service. What's critical for me and from this example is that we explored this from not just a social care point of view, not just a health point of view, but we also looked at how our provider market was changing. So in Herefordshire, we commissioned a Falls Responder Service that had telecare as I guess, the foundations, but it was a joint investment across the CCG, the social care, the local authority, and the provider themselves who saw this as an opportunity to grow their business. So strategically allowed us to reduce ambulance call-outs and attendance, preventing the unnecessary health and social care expenditure. Most importantly, from a patient or service user point of view, it allowed people to maintain their independence in their own home where possible, but also reduce their anxiety of potentially alerting via a telecare pendant, alerting someone to respond to if they've had a fall. Often on occasions they felt previously that they didn't want an ambulance coming to their home. It might feel that neighbours might wonder what's going on. It might feel that they're being intruded upon. So really it gave them another option, and it allowed us to do follow-up visits, whether that be promoting their confidence or linking them into other prevention services such as a risk management at home, whether it be the falls prevention service, or whether it actually be somebody to check on their lighting or the state of their carpets. Clinically, it allowed us, with the service, it allows us to actually tap into getting people out of hospital earlier, obviously where safe to do so, and also triage to other interventions, so that rather than perhaps using ambulance services and emergency services as the default, it allowed us to tap into nurses, particularly out of hours, when needed, and again avoiding those admissions to hospital. And from a financial point of view, it meant we made our money go further. We were reducing the cost of delivery of services and targeting across the most appropriate pathway. Next slide, please. So really, some points that you may well be aware of, but it's just really from lessons that we've learned both in Coventry and Herefordshire, looking at a technology rollout. The most important thing for me is, what is it the problem you're trying to solve? And making it very clear that from all stakeholders' point of view, that everybody's involved from the starting point, and it's just kept very simple, very straightforward, and clear messages for everybody. So looking at wider opportunities, whether that be looking for neighbouring local authorities and seeing the services they provide, or the services they commission, and see how you can work on that together. Identifying capacity within the system across other partners. And as I said, a clear identification of the what's in it for me for each stakeholder. Finally, really, it's looking at the benefits realisation. As I say, being very clear on what's cost avoidance and what's cost reduction. And for that, really, which is cost avoidance, what can you really suggest will have an impact on the bottom line? And really leaving the technology to last. It can be very easy to be seduced by certain technology or providers or suppliers out there, but really the technology is the easy part. It's really looking at what the outcomes you want to achieve, and then finding obviously the appropriate solution to achieve those outcomes. Next slide, please. And finally, just really making sure that we all remain clear that it's not just about the systems, the processes and the technology. It's very clear that the people and the culture are a key element of this. We need to bring people along with us rather than having them feel that it was done to them. Our staff need to be clear that they are involved and the behaviour change is vital to getting this realised, to make sure we meet our objectives and we realise our efficiencies. And that's it for me.